Ever considered that some symptoms, which seem like mental health issues, could actually be a warning sign of a metabolic disorder? Today, we're talking about late-onset Urea Cycle Disorder, UCD, a genetic metabolic disorder that is often misdiagnosed as a mental illness, mood disorder, or another neurological condition in the clinic, causing patients to miss out on the best chance for treatment. Especially in adults, the symptoms are often subtle and can go unnoticed. Once the metabolic imbalance sets in, it can rapidly worsen and become life-threatening. Next, we'll share a few real cases to show you. When delirium, hallucinations, or sudden mood swings appear, it's not just unstable emotions. If you catch UCD early, run the right tests, and administer the right treatment, you can often change the outcome, even save a life. Case 1. Postpartum Day 4, suddenly unable to speak clearly, a storm of ammonia, misdiagnosed as liver disease. On the 4th day after giving birth, a 23-year-old new mother visited the NICU to see her premature baby. A few hours later, her family noticed something was wrong. She was slurring her speech, seeing things blurry, and behaving oddly. By the time she arrived at the hospital, she could only respond to pain. Her speech was slurred, and her consciousness level was low. Emergency tests showed elevated ammonia levels in her blood, 158 micromoles per liter, low protein markers, and mildly elevated liver enzymes. However, a toxin screening came back negative, and imaging of her head and abdomen showed no acute issues, just some signs of fatty liver. Due to her decreased consciousness, she was intubated and transferred to the ICU. Initially, doctors suspected hepatic encephalopathy and started her on lactulose to help eliminate the ammonia, along with antibiotics and antivirals to prevent infection. The next day, her brain MRI was clear, and she was successfully extubated. However, her ammonia levels shot up to 400 micromoles per liter. This was no longer just a liver issue. The medical team shifted focus to a metabolic disorder and ordered amino acid tests in her urine and blood, along with genetic testing. On day 7, the results showed abnormally high citrulline levels in her urine, and by day 8, the ASS1 gene mutation confirmed a diagnosis of citrullinemia type 1, a genetic metabolic disorder, IEM. Treatment quickly changed direction. Medications like sodium phenylbutyrate to help remove excess nitrogen, along with arginine supplements. A low-protein diet to ensure enough calories without breaking down muscle for ammonia production. Her ammonia levels started to decrease, and her speech and awareness gradually returned. On day 9, her liver enzymes spiked again, and for safety, she was transferred to a liver transplant center for close monitoring. Eventually, her liver function improved, and she was discharged with instructions to continue nitrogen-clearing medications, take arginine, control protein intake, ensure adequate calories, and schedule regular follow-ups with genetic counseling. Doctors also advised against pregnancy in the short term. This case highlights an important lesson for pregnant and postpartum women. Pregnancy and childbirth bring hormonal fluctuations, increased protein needs, and greater liver metabolism stress. Combined with the pain, blood loss, and stress of delivery, it can trigger a storm of ammonia or overwhelm detoxification systems in people with hidden metabolic defects, leading to acute metabolic crises. For women with UCD, it's crucial to monitor ammonia levels during pregnancy, avoid high-protein diets, use nitrogen-clearing treatments if needed, and have a multidisciplinary team manage the situation to minimize risks. Case 2, from confusion and disorder to complete recovery. A 66-year-old man's emergency story. This is the emergency story of a 66-year-old man who initially had sinusitis. After using antibiotics, his condition didn't improve but actually worsened. At first, he felt a bit off, but in just a few days, his symptoms rapidly escalated, and he ultimately fell into a coma, requiring urgent hospitalization. A few weeks earlier, he had started taking levofloxacin to treat his sinusitis, but when his symptoms didn't improve, he was also prescribed methylprednisolone, a steroid, to help manage the inflammation, but that didn't help either. Soon after, he began experiencing headaches, stomach pain, nausea, and frequent waking during the night, accompanied by confusion. His family rushed him to the hospital. By the time he arrived at the ER, his consciousness was clouded, and he had become extremely disoriented and irritable to the point that intubation was required. The doctors conducted a thorough evaluation, initially suspecting infectious encephalitis, and began treating him for infection. However, cerebrospinal fluid tests showed no signs of infection, and an MRI of his brain revealed no acute abnormalities. The doctors then turned their attention to other potential causes. As his condition continued to deteriorate, his blood ammonia levels surged to 494 micrograms per deciliter, alerting the doctors to the possibility of hyperammonemia. They immediately began dialysis to rapidly lower his ammonia levels. Genetic testing eventually revealed the true cause: ornithine transcarbamylase deficiency, OTCD, a urea cycle disorder. The treatment plan was quickly adjusted. Lactulose was discontinued and replaced with nitrogen-clearing agents and arginine supplements, alongside dietary changes. A low-protein diet with increased caloric intake. Fortunately, the treatment worked. His ammonia levels began to drop and his consciousness gradually returned. After undergoing blood dialysis, his liver function also improved. Although his mental state showed some recovery, he still had some cognitive impairment, particularly in language and memory. Before discharge, the doctors recommended continued treatment with nitrogen-clearing agents and arginine, strict protein control in his diet, regular follow-ups, and genetic counseling. 3 weeks later, his symptoms had improved significantly, and his brain MRI showed a reduction in abnormal areas. After 3 months of follow-up, he had regained his pre-illness functional status. 6 months later, with long-term low-protein diet, nitrogen-clearing treatments, and regular monitoring, he remained in good health. The triggers for this episode were multiple: antibiotic treatment, steroids, and the patient's long-term use of red yeast rice supplements. Steroids may have worsened liver function, and red yeast rice can interact with other medications, leading to ammonia buildup and additional liver strain. Doctors emphasize the importance of carefully considering drug interactions, especially when dealing with liver dysfunction. This case reminds us to be particularly cautious with medication interactions, especially in patients with existing metabolic disorders. Case 3. A 34-year-old man's sudden mental symptoms. A mystery triggered by high-protein diet and intense exercise. This is the real emergency story of a 34-year-old man. Since the age of 30, he had experienced occasional strange behaviors like sudden screaming and talking to walls, which were initially thought to be psychological issues. Later, he started heavy weight training and consumed high amounts of whey protein every day. Over time, he began to feel fatigued and overly sleepy, and switching to soy protein provided slight relief. One night, he repeatedly told the same story, lit 2 cigarettes at once, and complained of blurry vision. His family rushed him to the ER. By the time he arrived, his vital signs were mostly normal, but his hands were shaking, and his handwriting was unsteady. Blood tests revealed mild hyperammonemia, 108 micromoles per liter, but his brain CT and MRI appeared normal. The doctors initially treated him for what they suspected might be epilepsy, giving him levetiracetam. On the second day, his symptoms slightly improved, but his vision remained blurry. On day 3, an EEG showed signs of metabolic dysfunction. By day 7, his blood ammonia levels rose to 173 micromoles per liter. On day 8, he was discharged with advice to reduce protein intake. But after discharge, he still experienced occasional blurred vision and slurred speech. On day 31, he returned to the hospital with symptoms of drowsiness, hand tremors, and unusual behavior. His blood ammonia level was 122 micromoles per liter. After asking more about his medical history, the doctors learned that he feels unwell after eating chicken, and that his uncle had died mysteriously at the age of 2. This raised strong suspicions of a metabolic disorder, specifically a urea cycle disorder, UCD. By day 33, the doctors immediately restricted his protein intake to about 40 grams per day and gave him intravenous arginine. On day 34, his vision cleared up, his mental state improved, and his blood ammonia levels returned to normal. He was started on oral sodium phenylbutyrate, 4.5 grams per day. Further tests revealed that his blood glutamine was elevated, his arginine was low, and his citrulline was normal. His urine showed a significant rise in whey acid, and, combined with genetic testing, he was ultimately diagnosed with ornithine transcarbamylase deficiency, OTCD. By day 44, the patient was discharged, and his blood ammonia levels remained stable, with no recurrence of symptoms. The biggest trigger behind his sudden mental and neurological symptoms was the high-protein diet combined with intense exercise. The protein increased ammonia production in his body, and the heavy exercise amplified muscle metabolism. Together, these two factors overwhelmed his already compromised detoxification system, causing the sudden onset of symptoms. However, once his protein intake was restricted, essential metabolites were supplemented, and nitrogen-clearing medications were used to lower his ammonia levels. The fog began to lift, and his symptoms resolved. Case 4. A 59-year-old man's coma unveils a family history of metabolic disorder. This is the story of a 59-year-old man, which begins with him saying, "I've just been feeling so tired." For the past 3 months, he'd been experiencing increasing drowsiness and sluggish responses. 3 days before being admitted to the hospital, he ate a large amount of high-protein food at a gathering, dog meat, chicken, and freshwater snails, followed by frequent vomiting. The next morning, he couldn't be woken up, and when he did speak, it was garbled. His family rushed him to the hospital. Upon arrival, his vital signs were stable, but he was nearly in a coma, GCS 10 out of 15. Imaging didn't show any acute abnormalities, but blood tests revealed a significant increase in his ammonia levels, 143.8 micromoles per liter. Initially, doctors treated him with lactulose, but his condition didn't improve. They quickly started dialysis, and during the process, he began having generalized seizures, which were relieved with intravenous lorazepam. Strongly suspecting a metabolic cause, the medical team continued to administer intravenous glucose, stopped external protein intake temporarily, and gave him arginine, sodium phenylbutyrate, and a protein-free formula via a gastric tube. The next day, his blood ammonia levels dropped to 36 micromoles per liter. However, they rose again to 107 micromoles per liter, so a second dialysis session was performed, continuing metabolic support. Ultimately, his blood ammonia levels stabilized below 30 micromoles per liter. Further laboratory tests confirmed the diagnosis. His blood amino acids showed elevated ornithine, glutamine, and lysine, while citrulline was low. His urine organic acids showed increased leucine acid and a slight increase in uracil. With this information, he was diagnosed with late-onset ornithine transcarbamylase deficiency, OTCD. Over the following days, his consciousness and speech gradually improved. After 2 weeks in the hospital, he was discharged with a low-protein, high-calorie diet plan, nitrogen-clearing medications, and an emergency care plan. When the family history was reviewed, it revealed an interesting pattern. The patient's 4 uncles had mysteriously passed away as children after eating large amounts of meat. In the patient's childhood, he also had recurrent abdominal pain and periodic seizures, which tied in with his diagnosis. It's important to note that OTCD is the only X-linked urea cycle disorder. The mutation can range from completely inactive, leading to severe symptoms in newborns, to partially active, where symptoms in adulthood are triggered by infection, surgery, medications like valproic acid, or a single high-protein load. Many patients are not diagnosed until adulthood, when a seemingly random metabolic crisis leads to identification. Case 5. From psychiatric symptoms to seizures. A 46-year-old man's acute onset story. This is the full emergency story of a 46-year-old man. He was diagnosed with schizophrenia at 15 and had been taking aripiprazole and valproic acid for years. He also had high blood pressure and a history of recurrent tonsillitis, with the last episode occurring just 4 days before his hospitalization. A few days before his acute symptoms began, his family noticed a sudden increase in his agitation. He was pacing back and forth all night, then started vomiting, becoming sluggish and even failing to recognize his family members. He was quickly rushed to the hospital. Initially, the family thought it was just an exacerbation of his psychiatric symptoms. However, upon arrival at the ER, he began showing signs of agitation and uncontrollable seizures. The usual medications didn't work, and he was transferred to the ICU for deep sedation, intubation, and ventilation support. The initial CT scan and cerebrospinal fluid (CSF) tests didn't show any clear abnormalities. 12 hours later, his condition worsened. He developed subtle eyelid tremors and a diminished pupillary response. A repeat CT scan revealed severe brain swelling with a risk of brain herniation. Given that he was on valproic acid, the medical team began suspecting a non-hepatic hyperammonemic encephalopathy. A blood test revealed an ammonia level of 557 micromoles per liter, far higher than normal. They immediately administered L-carnitine and called in a metabolic specialist for consultation. Further metabolic tests showed significantly elevated blood glutamine levels, secondary increases in blood lysine, and elevated leucine acid and uracil in his urine, indicating a potential urea cycle disorder. Ornithine transcarbamylase deficiency, OTCD, was highly suspected. Treatment was quickly shifted. All protein intake was halted, intravenous glucose was given to reduce self-damage, and dialysis was started to rapidly clear the ammonia from his system. After several rounds of treatment, his blood ammonia level gradually decreased to near normal levels, but his neurological function didn't improve. He lost brainstem reflexes and became hemodynamically unstable. Unfortunately, he went into cardiac arrest and passed away despite efforts to revive him. Retrospective genetic testing confirmed that the patient was a hemizygote for the pathogenic OTC mutation. His family underwent genetic counseling and planned for genetic screening of other family members. Looking back, this acute decompensation was likely triggered by a combination of factors: his underlying metabolic vulnerability, the stress from recent tonsillitis, and the potential for valproic acid to trigger or worsen hyperammonemia, which led to the seizures and fatal brain swelling. Late-onset UCD and its psychiatric symptoms. Late-onset Urea Cycle Disorder, UCD, is often mistaken for a psychiatric issue, but at its core, it's a problem with protein metabolism. Aside from ornithine transcarbamylase deficiency, OTCD, which is X-linked, most forms of UCD are inherited in an autosomal recessive manner. They affect around 8 different enzymes or transport proteins in the urea cycle. While some severe cases lead to coma in newborns due to high ammonia levels, other individuals may have some enzyme activity left, allowing them to remain stable into childhood or even adulthood until a triggering factor causes the disease to flare up. Under normal conditions, ammonia produced by protein breakdown in the body is processed by the urea cycle and turned into urea, which is then excreted by the kidneys. But in UCD, this pathway is blocked. As a result, ammonia and other byproducts build up, crossing the blood-brain barrier and entering the brain. When ammonia levels rise, astrocytes, cells in the brain that act as cleaners, combine it with glutamate to form glutamine. Glutamine is a small molecule that attracts water, and as it accumulates, it causes cells to swell, leading to brain edema and increased intracranial pressure. In severe cases, this can lead to coma or even be life-threatening. 1. Clinical symptoms of late onset, UCD adult. Onset, Urea Cycle Disorder. UCD often presents as psychiatric symptoms, initially showing up as sudden behavior changes, confusion, agitation, and even hallucinations, mood swings, or impulsive actions. These symptoms are easily misdiagnosed as mental health disorders or drug toxicity. Along with these, patients may experience drowsiness, unsteady walking, seizures, and in severe cases, coma. Blood ammonia levels can spike anywhere from 180 to 600 micromoles per liter, greatly increasing the risk of disability and death. Some individuals develop symptoms like vomiting, hallucinations, and emotional instability after taking corticosteroids, valproic acid, or consuming a high-protein diet. If ammonia levels remain elevated or spike intermittently, patients may experience sleep disturbances, delusions, hallucinations, and even symptoms resembling mental illness. These individuals are also at a higher risk for anxiety, depression, ADHD, autism spectrum-like behaviors, and personality changes. Clinically, adult patients often present with confusion, slurred speech, poor orientation, extreme agitation, delirium, or even stroke-like symptoms, which closely resemble schizophrenia or bipolar disorder. If misdiagnosed and untreated, this can lead to irreversible brain damage, coma, or even death. A special note for OTCD: many individuals don't experience mental health decline until adulthood, often accompanied by headaches, vomiting, an aversion to high-protein foods, and seizures. 2. Triggering factors. Late-onset UCD is often triggered by a straw that broke the camel's back. These patients still retain some enzyme activity and may instinctively avoid meat or lean towards a vegetarian diet. However, when faced with stress or a high protein load, their psychiatric symptoms can suddenly explode. Common scenarios include binge eating, consuming protein powders for fitness, or, in female patients, eating large amounts of meat shortly after childbirth. Studies show that a high-protein diet can cause rapid deterioration and even coma in late-onset OTC patients within hours. Infections, trauma, surgery, and childbirth can all accelerate the breakdown of body proteins, exceeding the body's ability to clear ammonia. Postpartum hormonal fluctuations and metabolic stress are especially dangerous. Certain medications, such as valproic acid, corticosteroids, and intravenous amino acids, can further inhibit ammonia clearance or increase protein breakdown. On the flip side, excessive fasting, extreme dieting, or even long-term strict vegetarianism can lead to insufficient calories, forcing the body to burn its own proteins, triggering hyperammonemia. 3. Clinical diagnostic clues. To avoid missing a late-onset UCD diagnosis in clinical practice, there's one master switch. Always consider hyperammonemia. When taking a patient's history, don't just focus on the present symptoms. Extend the timeline. Ask if there have been any unexplained neonatal deaths, unexplained comas, or family members who have been repeatedly labeled with mental illness without a clear cause. Pay attention to whether the patient instinctively avoids meat or prefers a low-protein or vegetarian diet. This could be their body's way of self-regulating nitrogen. Also, keep an eye out for a special exception, citrullinemia type 2, Harter syndrome. Unlike other forms, patients with this condition need to avoid high-carbohydrate diets. They tend to prefer high-fat foods and dislike sugar. For adult patients, inquire about any recent infections, surgeries, pregnancy, or postpartum periods. Use of medications like valproic acid or corticosteroids, alcohol consumption or sudden changes in diet or weight loss methods. Also, check if they are currently getting enough nutrition or calories. Any of these factors could be the straw that broke the camel's back. If any of these clues are present, make sure to prioritize a blood ammonia test. It's quick, inexpensive, and often the first step in turning things around. 4. Discussion and recommendations. Late onset. UCD is a disease that's easily overlooked but potentially deadly. As ammonia builds up in the body, it damages the brain, which often leads to mental abnormalities as the first signs, things like sudden agitation, rambling speech, hallucinations, and emotional instability. These symptoms are often accompanied by unsteady walking, fluctuating drowsiness and irritability, seizures, and even stomach discomfort. To reduce misdiagnosis, the first step is to think one step further. For any patient of any age suddenly presenting with recurring mental symptoms, confusion, or even coma, be sure to prioritize a blood ammonia test, especially if they tend to avoid meat or have family members with unexplained comas or neonatal deaths. Early screening and early referral are simple yet life-saving. On a daily basis, patients should avoid triggers like overeating protein, extreme dieting, or fasting, and be cautious when using medications like valproic acid or corticosteroids. During high-stress moments like infections, surgeries, or pregnancy, postpartum periods, closer monitoring is key. In terms of treatment, the goal during the acute phase is clear. Reduce ammonia levels as quickly as possible. Dialysis may be necessary, along with nitrogen-removing medications and arginine. Once stabilized, patients should maintain a low-protein diet, adequate caloric intake, and regular follow-ups. If there's a history of recurrent episodes or severe neurological damage, it's important to evaluate the possibility of liver transplantation early on. This entire process requires multidisciplinary collaboration, working together with specialists from psychiatry, neurology, gastroenterology/hepatology, genetics, and nutrition teams ensures that nothing is overlooked and the best treatment window is not missed. Conclusion: the mental abnormalities seen in late-onset urea cycle disorder, UCD, are caused by IEM, inborn errors of metabolism, leading to genetic metabolic brain diseases, GMBDS. These often disguise themselves as common emotional or mental health issues, like agitation, incoherent speech, and sudden behavior changes, appearing as old habits but hiding a dangerous crisis. Because they mimic common mental illnesses, many people go undiagnosed for a long time, suffering silently and sometimes worsening over time. The key is heightened awareness. When a patient experiences recurrent or sudden mental changes, the first thought should be to check ammonia levels and quickly involve specialists from psychiatry, neurology, hepatology/gastroenterology, genetics, and nutrition. Catching the issue during the golden hour can often save a patient from the brink of disaster, preventing irreversible brain damage or even death. Recognizing these signs doesn't just save lives, it helps patients return to a normal life, reduces relapses, and frees them from the dual burden of physical and mental suffering. If you want to learn more about inborn errors of metabolism, IEM, and their connection to mental health issues, specifically metabolic psychiatric disorders, be sure to subscribe to my channel.